Okay, everyone, let's get started. My name is Matt Cicchini, and this is our first case in the pulmonary high yield section from these case reviews. And so, what we can see from low power here is we have resection of the lung, and we have this unencapsulated lesion, but that is relatively well circumscribed from the adjacent lung parenchyma, which at this low power looks relatively normal. When we zoom into a higher power, we start to see these complex glandular structures forming these central lumina. And then we move to a little bit higher power, we can see that these cells are lined by these columnar cells that have elongated pencillate nuclei. They're fairly atypical with some pleomorphism. They do have some prominent nucleoli. We do see mitotic figures. And the other key feature here is we're starting to see this luminal necrosis within the lumen of these poorly formed glandular structures. This is often referred to as so-called dirty necrosis, and that is a characteristic feature of this tumor. And so right now we would be at an adenocarcinoma. You can also notice the desmoplastic stromal reaction associated with this. And for an adenocarcinoma, it's important to think whether this is a primary tumor or a metastatic tumor. A lot of times the history can help you a great deal. So in this case, the patient had a history of a colorectal carcinoma, as well as bilateral lung masses. And this morphology is very classic for a metastatic colorectal cancer, with this columnar appearance of the cells and this luminal necrosis. However, in some cases, it might be a bit more challenging to differentiate between a primary and a metastatic tumor. It's important to note that this tumor, which has an immunophenotype of cytokeratin 20 positive, CDX2 positive, cytokeratin 7 negative, and TTF1 negative, can be seen in both primary and metastatic tumors. So it's most commonly seen in colorectal cancers, but a subset of primary lung carcinomas can also be positive for CDX2. So none of these markers are completely sensitive or specific. So it is important to correlate with the clinical imaging as well as history. And so, in terms of some information around metastasis, so metastases are often the most common pulmonary malignancy we see. If we look at actually an autopsy series, a lung is the third most common site for metastasis after a lymph node and liver. And a common metastasis that we see in the lung include GI, breast, head and neck. And you can also see metastatic sarcomas and melanomas. Classically, at low power, these will be cannonball-like lesions, which are kind of well circumscribed, and that's how you'll see it on gross as well. But in cancer specimens, it's also important to look at the background lung parenchyma. And as we're moving through here, we can start to see some other abnormalities in the lung. And so you'll notice there's these well-formed, non-necrotizing granulomas. And just as a reminder, a granuloma just means a collection of these epithelioid histiocytes with associated lymphocytes around it. And so in these cases, they're relatively poor in the number of lymphocytes. They're mainly these epithelioid histiocytes, and they just have a thin rim of these lymphocytes sprinkled around them. And they're very well-formed granulomas. As you move around, you also see some multinucleated giant cells associated with these granulomas. You can see here some more as well. Many of these do have endogenous calcifications. So these aren't foreign material. This is just endogenous calcifications that can occur in these giant cells. And then the other important thing to notice is the distribution of these granulomas. And so as I'm just going to go to lower power here, you can see them tracking along the interlobular septa here. You can also see them associated with these bronchovascular bundles. We don't have good pleura in this section, but you'd also see them tracking along the pleura. So this combination of involving the bronchovascular bundles, interlobular septa, and subpleura is consistent with a lymphangitic distribution. So putting this together, these features are most consistent with sarcoidosis. However, this is typically a diagnosis of exclusion, and other causes of non of granulomatous inflammation, including infectious such as mycobacterial or fungal, should be considered and excluded. Hypersensitivity and pneumonia typically has more poorly formed granulomas, but may be considered. An important beryllium exposure can cause a very similar appearance to sarcoidosis that is essentially histologically indistinguishable. So it's important to exclude that based on history. So that's our first case. It's a metastatic colorectal carcinoma that shows this infiltration of these complex glandular structures with a desmoplastic stromal reaction. It has this intraluminal necrosis or dirty necrosis of the cells. An important point to remember is that the immunophenotype for this, well, can lead you to think about colorectal cancer. It's not completely specific, as a subset of lung carcinomas can also be positive for CDX2 with a more enteric immunophenotype. And then just highlighting the importance of also looking at the background lung. In this case, there was non-necrotizing granulose inflammation that was consistent with sarcoidosis. So that's our first case. Just going to move on to our second case here. We have another surgical wedge biopsy, and this is a case of lymphangioliomatosis or LAM. So you can see at low power, we start to see these cystic areas. So whenever you see cysts, you really want to know what the lining is, and the lung is no exception. So if we go down and look at higher power, we can see these cysts that are lined by these relatively thin wall, but underneath the wall of the cyst, we start to see this proliferation of cells. And these proliferation of cells have almost a nodular appearance. And the cells range from more epithelioid to spindled as we move around. Some of their nuclei are a bit oval to kind of more cigar shaped. And then if we go to higher power, it's a little bit hard to see, but they do have a bit of kind of vesicular type of chromatin, and but they're relatively bland. And so this proliferation of spindle cells underneath these thin-walled cysts should make you think of a lymphangioliomatosis or LAM. So these cases have a interesting immunophenotype. And so they're typically strongly positive for smooth muscle markers, including smooth actin, desmin, and vimentin. But they have this distinctive feature for immunoreactivity for HMB45 and melon A. So they're often put in this category of PEComa-like lesions or tumors. These tumors typically occur in women of reproductive age, and it's associated with tuberous sclerosis. These patients can present with a pneumothorax, dyspnea, and hemoptysis. And this proliferation of these spindle cells often obstructs the lymphatics. And so this can produce a characteristic chylous effusion, which would appear very white, as a white effusion. You can see more of the proliferation of the spindle cells here. And in this association, they're associated with mutations in TSC1 and 2. And these patients can often have the other features of tuberous sclerosis. And so if you get a history in a patient who has a cyst in their lungs, typically a younger woman, that also has renal masses, you should really think about, could this be a case of LAM? Great, thanks. So let's move on to our next case. So we have some smaller biopsies here this time. These are probably either a cryobiopsy or larger transbronchial biopsies. And we once again see this alveolar lung parenchyma. And so when you're looking at the lung parenchyma, you really want to make a concerted effort to look at all the components of the lung. And so specifically, you want to look at the interstitium, you want to look at the air spaces, as well as you want to look at the vessels as well. So in this case, when we're looking at it, the interstitium looks pretty good, nice, relatively thin alveolar septum, maybe a little bit expanded by some inflammatory cells. I think really the abnormality here is within these air spaces, where you have this kind of material accumulating within the air spaces. And if we look at it a bit closer, we notice that it has a bit of this kind of frothy appearance to it as well. And where it's kind of has a mix of almost looking like fibrin, but it appears bubbly or frothy here as well. And so those are some key buzzwords for this diagnosis. And the other thing you notice is that it's relatively poor in inflammatory cell infiltrate, where we have some, but really it's not a lot of reaction to this. And so this kind of particular exudate is really pathognomonic for pneumocystis. And so in these cases, it's really important that we do a GMS. So this is a GMS stain from a different case. And I think you can nicely see the positivity of the pneumocystis organisms here. And so on GMS, we typically see them as these clusters, and it's within this kind of frothy exudate. They can have this round, flattened appearance. And some of these flattened appearances actually makes them look like they're almost like a crushed ping pong ball. So if you were to take one of those small white ping pong balls and crush it, you might get an appearance like this. And then in many of them, you see that within the organism here, you have this kind of darker staining body. And so this is known as the intracystic body as well. So the main differential for this is histoplasmosis and cryptococcus. Histo is typically smaller and will show budding. Pneumocystis shouldn't show any budding. And cryptococcus varies more in size, and they often have a thick capsule. And so this is a nice classic case of a pneumocystis. Perfect. Okay, so moving forward, we have another lung resection here. And you can see the background lung looks pretty good, but then we have these large areas of abnormalities. And then they're kind of really clustering together. And so these are actually necrotizing granulomas in contrast to our case of sarcoidosis where we had non-necrotizing granulomas. You can see there's prominent necrosis here. You can see it all the way throughout. And these necrotizing granulomas are quite large and clustered together. And then we do see prominent multinucleated giant cells associated with them. And so you can see a spectrum of multinucleated giant cells. However, some of them do have this characteristic appearance that are known as Langhans type giant cells, where these nuclei are often at the periphery of the cell, and they have this horseshoe type of appearance here. And so this case with these large necrotizing granulomas should be very suspicious for an infectious etiology. So it's critically important that you perform histochemical stains to exclude a fungal and acid-fast organisms. And so in this case, it was actually positive for acid-fast bacilli. And the acid-fast bacilli were these tiny curved structures, and there was only a few organisms throughout the slide. So that's most in keeping with the tuberculosis. And an important point here is that it's important to stain at least one block or multiple blocks ideally, because these can be really focal. And you really have to hunt for these organisms at least 40x, spend some time to look through them, because in this large section, you may only find a few organisms, and that is clinically relevant. The differential for this is fungal etiologies as well as sarcoid enters in the differential, but that's more classically a non-necrotizing granulomatous inflammation. You can get necrotizing sarcoid, but you would not expect to have these large areas of necrosis. Rheumatoid nodules as well as granulomatosis with polyangiitis, but we're not seeing any background vasculitis. And the giant cells have a bit of a different appearance, GPA, where they're much more hyperchromatic. And we're not really seeing large geographic changes and really blue necrosis. So taken together, this is most common, most consistent with an infectious etiology. In this case, it was tuberculosis. It's a great job. So continuing on, so this is our next case here. So you can see that this is likely a central mass, as we have a large airway here with these cartilage here. And you can see at low power, we have this relatively well circumscribed lesion here. And when we move down to a bit higher power, we can see that it has this kind of organoid appearance where we have these nests of cells that are interspersed by this fine, delicate vasculature pattern. And the cells are kind of more epithelioid to a little bit spindled in areas as well. And when we look down at higher power, we see that the nuclei have this characteristic appearance with this really stippled chromatin that really is described as this salt and pepper chromatin. So the salt is the fine specks, and the larger, coarser bits are the pepper. And so that gives you the salt and pepper appearance to it. So this morphology and that chromatin is really consistent with a neuroendocrine tumor. And so in the lung, we classify these as carcinoid tumors. And then we further subclassify them into typical and atypical carcinoid. And the distinguishing feature is the presence of mitoses as well as necrosis. And so you have to go through and count the number of mitotic figures. And so you're counting per 2 millimeters squared. And tumors that have less than two mitotic figures per 2 millimeters squared are classified as typical carcinoids. And atypical carcinoids have between 2 and 10 mitotic figures. And necrosis, and in terms of necrosis, typical carcinoids should not have any necrosis, and atypical carcinoids can have focal areas of necrosis. Once you start getting more than 10 mitotic figures per 2 millimeters squared, you should start to think about a higher grade neuroendocrine tumor, such as a small cell carcinoma or a large cell carcinoma. But typically, these have much more than 10 mitotic figures per 2 millimeters squared. Typically, you're on the order of 50 or more. And so in this case, we're really not finding any mitotic activity. And as I'm moving around, you're not really seeing any necrosis either. So this tumor is best characterized as a typical carcinoid. Just as a point, we typically don't make the distinction between a typical and an atypical carcinoid on a small biopsy because these can be heterogeneous. But it is important to point out if you do see lots of mitotic activity or necrosis, as that may signify a higher grade lesion. Some of this does look a little bit more spindled, and that's another important point as carcinoid tumors in the lung can be quite spindled looking, especially in the peripheral lesions. And so if you get a spindled lesion before you jump to some type of sarcoma, you should always consider, could this be a carcinoid tumor with a bit more of a spindle cell morphology? Perfect, so that's great. So let's keep moving ahead. So our next case here, we see that we have largely normal lung, but we have this nice area of abnormality here. So when we look down at a little higher power, we see that's composed. I think the first thing that jumps out of your eye is the number of eosinophils. So all throughout this, we have abundant eosinophils throughout this lesion. So that should tip you off a bit to diagnosis. And then interspersed between here, we have these other cell type, and they really have these indistinct cell borders. And then they have these nuclei that characteristically have this grooved appearance in their nuclei. So I think you can see a nice nuclear groove there. And you can kind of see that throughout, and they kind of have these irregular borders as well. They can have somewhat prominent nucleoli as well. And so these are all Langerhans cells, and the association with these eosinophils really makes you think of a pulmonary Langerhans cell histiocytosis. And so you can confirm this in a few ways. So you can do a CD1A, which will highlight all these clusters of Langerhans cells, which is pathognomonic for the diagnosis of pulmonary Langerhans cell histiocytosis. Um, Electron microscopy, which can often appear on, is a high yield fact for preparing for board exams, has characteristic EM features that are known as Burbeck granules, and they have this classic rod-like appearance with a pentalaminar appearance. And really the way I remember them is they kind of look like tennis rackets as well. And so this is a smoking related disease typically that is typically treated first with just smoking cessation. However, a subset of these cases can actually also have BRAF mutations, which may be important as some of these patients could be treated if they have progressive disease with BRAF inhibitors. So you can find a BRAF V600E mutation in approximately half of these cases. Perfect. So our next lesion here, we see once again we have a large central airway here with this cartilage, and it's lined by this bronchial type epithelium. And you can see it's diffusely involved. We have these large areas of necrosis, but the rest of it is really just a sea of blue cells. So then when we look down at higher power, we see this diffuse sheets of these cells. They are relatively cohesive, but they're not really forming any structures. I do want you to notice that they look a little bit on the monotonous side. While there's lots of mitotic activity and there's areas of necrosis, they all look very similar to one another. We're not really seeing a ton of pleomorphism and atypia. They're really a little bit on the monotonous portion that should kind of clue you into the diagnosis. So as we look through these areas, we're not seeing any definite glandular or squamous differentiation. But if you move down to here, sorry, just move a little bit quickly. You do see some areas where we go from this really primitive looking cell type to where we're actually forming keratin. So this is what we call this abrupt keratinization, where you go from this really primitive looking cell to kind of this cell that's forming keratin. So that's a real good clue to the diagnosis in this case. So this is actually a nut carcinoma. And so that is a characteristic feature of it. So this is actually a translocation-driven tumor that often occurs in the midline, but not always. Classically occurs in younger males. You can see it within the lung, mediastinum, as well as head and neck. These are typically quite aggressive tumors, and they're characterized by a translocation between NUT and BRD4, which causes an interesting mechanism of tumorigenesis, where this complex between NUT and BRD4 will bind to acetylated histones on the DNA and then recruit P300, which will then put down more acetylation marks on the histones that allow propagation of these complexes between NUT and BRD4 to cover large areas of the chromatin to cause this changes in gene expression that allow it to adopt this really primitive phenotype. Interestingly, if you knock this complex off, that actually causes the cells to abruptly differentiate into squamous cells and die. And people are currently exploring the use of BRD4 inhibitors and other inhibitors to target this. So it's an important diagnosis to make because these patients can have a quite aggressive course, and there is a potential for targeted therapies in the future. The differential for this case would be a more basaloid squamous cell carcinoma or a poorly differentiated adenocarcinoma. These cases can have variable staining for P40 and TTF1. In some cases, they'll co-express both P40 and TTF1. So that's another tip for these. If you see co-expression of those two markers, you may want to consider a nut carcinoma. There's a good immunostain for this that does highlight a nice speckled pattern in the nuclei that is characteristic for it as well. So moving to our next case here, we have two slides. So you can see at low power, we have almost a cystic type area here, and then some relatively normal lung parenchyma. If you actually look down in here within the blood, you can actually see these structures here. So these structures are actually organisms, and so these are actually protoscolices from an echinococcus. And the one nice feature here is you can see really nice hooklets here. That one's a little bit out of focus in the slide, so I think we'll move around and see a few more. Another one here cut in a bit of an odd section. You can also see these calcified structures, which are known as calcaneous corpuscles, that are also features of this organism and thought to play a role in excreting waste and also as a storage system for calcium and other material. So you can see quite a few of these organisms here. Here's another one. So these are protoscolices, which are the juvenile form of this worm. And so the life cycle of this worm is actually in the definitive host, which are typically wolves or dogs. They will form the full adult worm in their intestinal tract, which will then lay the eggs, which can then be ingested by a secondary host, including humans, which will then hatch within the our GI system, and then they will penetrate through the intestinal wall, where they can then enter the bloodstream and then get to various organs. So these will form these cystic structures in both the lung, liver, as well as they can occur in the brain, and then they'll form these protoscolices. And the way that the infection cycle continues, if then this tissue were to be ingested by a wolf or a dog, they could then reform the full adult worm and continue the life cycle. This is another section from the case which shows the wall of the cyst, which has this characteristic appearance. It has this characteristic laminated appearance here. If you look at high power, it almost looks like you're looking at the rings of Saturn, where you have this concentric layers of material. This is positive on GMS, as well as they have this granular cell layer here, which I'll just move up to here, which I think shows it a little bit nicer. You have this granular cell layer here, and then on top of it, you can see some protoscolices as well as this calcaneous corpuscles. So this granular cell layer is actually what forms these protoscolices. And so I kind of think of it as this is like a factory that is then producing these juvenile forms of the worm. So it has this kind of interesting mechanism of propagation. And if this granular cell layer, any of this is actually left in the patient, this is actually what can continue to cause disease as well. So this is a classic case of a hydatid cyst or a echinococcus. So our next case here, we have another resection from the lung. And at low power, I think you can really see we have this nice, really well circumscribed lesion. And I think even at this low power, you can make out that it looks somewhat cartilaginous, as well as you can see this adipose tissue here as well. So when we zoom down to higher power, we can see nice, well-formed cartilage, as well as this more chondromyxoid tissue and a mixture of mature adipose tissue. The other important feature here is we do have this entrapped bronchial epithelium that kind of is in multiple areas. And so these are the features that are characteristic of a pulmonary hamartoma that we're seeing both with this chondroid tissue, this chondromyxoid tissue, adipose tissue, and then you do have entrapped glandular structures as well. So this is a pulmonary hamartoma. So our next case here is surgical resection here. You can see it's fairly abnormal even at this low power, where we start to see this quite cellular areas. And we do see a lot of blood as well. Just a note about blood in the lungs. Much of it is actually artifactual. That's from the procedure itself. But real hemorrhage is when you start to see this hemosiderin deposition that accumulates in these alveolar macrophages here. And so the hemosiderin is typically this kind of brown, chunkier pigment that you can see throughout this case. And so this further suggests, along with there's some focal areas of fibrin as well, there's an aspect of hemorrhage associated with this lesion. So we zoom back out to a little bit lower power. You can see that there's this cellular area here that's really tracking along the bronchovascular bundle. So that we have an airway and a vessel here. We have this cellular proliferation around the bronchovascular bundles. It's also a bit in the interlobular septa. And then when we go down to higher power, we can see that it's a spindle cell proliferation. And it's the proliferation of these relatively bland cells. We do note that there's relatively prominent ectatic vasculature associated with this lesion, as well as we see that some of the cells actually have intracytoplasmic lumina, as well as we see a number of extravasated red blood cells as well throughout. And so this should clue into your mind that this could be a vascular lesion. And an important vascular lesion in the lung is actually a Kaposi sarcoma, which typically has this relatively monotonous proliferation of these spindle cells and these fascicles. We see these complex vascular channels. We often see extravasated red blood cells and intracytoplasmic lumina formation. And then we can confirm this diagnosis with actually an immunohistochemical stain. So this is an immunohistochemical stain for HHV8, which is positive in Kaposi sarcoma. And so these cases are classically associated with HIV, in which they develop, and or other immunodeficiency states. Our next case here at low power, you can see it's quite abnormal, even at this low power magnification, where the alveolar septa appears fairly thickened. When we zoom down to higher power, we can see that it's thickened by this material that doesn't really have the same appearance of fibrosis. It's relatively more of this amorphous appearing material that has this prominent cracking artifact. And there's also an area down here, I'm just going to move down here, where we see a more nodular accumulation of this similar type of material, where it has this homogeneous amorphous appearance that's relatively acellular with this cracking artifact to it. And so this is a classic appearance for amyloid. And we can also, if you find some vessels, it actually is involved in a number of the vessels as well here. So you can see here we have a accumulation of this material within inside the vessel walls as well. But it's diffused throughout this section here. And so this really has the appearance of amyloid, and we characterize this as a septal amyloidosis. So there's three main categories of amyloid that can involve the lung. We classify them as septal amyloidosis, which is this case where you have the amyloid deposited in the alveolar walls. Nodular amyloidosis is when you just have a localized accumulation of this. And then there's another type of amyloidosis known as tracheobronchial amyloidosis, which occurs associated with the airways. In order to prove this, you can do a Congo red histochemical stain. So you can see in this case, we have diffuse accumulation of this congophilic material in the alveolar walls. You can see it highlighted clearly around vessels. as well as in the more nodular area of the section as well. You can see a significant accumulation of this conchophilic material. To identify the type of amyloid that's being deposited, the best test is to do mass spec to find out the underlying protein that is accumulating, whether it's light chain or transthyretin. So moving on to our next case here, we have a resection from the lung. So I'm just going to move it this way so we can nicely orient it. So this is our pleural surface here, and this is the kind of resection area kind of away from the pleural surface. You can see that most of it is actually quite diffusely involved. However, if we look at the distribution, it appears to be much worse just underneath the pleural surface, where we have some spared lung away from the pleural surface. So I would say that we have a subpleural distribution of fibrosis. The other thing I would point out is the fact that it is patchy. So we have some areas of dense abnormality with this fibrosis and these large areas of architectural change juxtaposed against the areas here where we have relatively normal lung parenchyma. So if we zoom down to higher power, we can see that there's this dense fibrosis, and there's these areas, these cystically dilated spaces here that are lined by this metaplastic bronchial type of epithelium, where we have this ciliated pseudostratified columnar mucosa there. And these areas actually stack on top of each other. And so this is characteristic of microscopic honeycomb change in these areas of dense fibrosis. As well as we see some areas with a bit more of loose fibroblast proliferation. You can see there. Just going to move around here to find some other areas. So you can see here as well, see how these stand out at low power, where the fibroblasts here have a bit of a different character to it, where it's a bit more of a loose proliferation of these, and they tend to bulge into these air spaces. And so these here are actually fibroblastic foci. So I'm just going to draw it out there. So this is a fibroblastic focus. There's another one here. And it's characterized by this kind of loose proliferation of fibroblasts that push into the airspace here. And then juxtaposed against this, we have some normal lung parenchyma. So this is a case of a usual interstitial pneumonia, which has both temporal and spatial heterogeneity. The temporal heterogeneity means just on the single slide that we can see different phases of the disease all in the same slide. And so I like to think of it as the past, present, and future. So the past being this already densely fibrotic lung with this microscopic honeycomb change. This is the lung that's essentially gone. And then the present being these areas of active fibrosis, so these fibroblastic foci, and then the future being the uninvolved lung parenchyma that will ultimately become fibrosis as this disease progresses. And then the spatial heterogeneity just means that if you look at different areas in the lung, it has a very different characteristic appearance from this dense fibrosis to this uninvolved lung or to the fibroblastic foci. So this is temporal and spatial heterogeneity. In contrast, if we look at this case, which is our next case here, you see that it has a much more uniform appearance, where we're not really seeing temporal or spatial heterogeneity. It really looks the same as we go throughout. And the architecture is relatively preserved. Instead of having big dilated cystically dilated spaces with microscopic honeycomb change, we're just seeing a really thickening of the alveolar septa. If we look down at higher power, we can see that the walls are thickened by this fibrotic process where we're seeing fibrosis of these alveolar walls. And there is some minimal chronic inflammatory infiltrate associated with this as well. So this would be a case characteristic of a fibrotic non-specific interstitial pneumonia or a fibrotic NSIP, where we have this relatively uniform fibrotic process involving the specimen here, in contrast to our UIP case, which had both temporal and spatial heterogeneity. So the next case here, we have another surgical wedge biopsy shown here. And you can see there's an area of localized abnormality here. So if we go down to higher power, we can see that the architecture is largely maintained. So if I highlight out here, you can see the maintained alveolar walls. But we seem to have something filling the alveolar spaces. And then if we look at a little bit higher power, it appears to be these proliferating fibroblasts. And the fibroblasts have a very loose picture to them, and they almost have this mucopolysaccharide-rich appearance. and they seem to be plugging and filling up these alveolar spaces. And so we call these fibroblastic plugs, and they were previously described as Masson's bodies. And so important distinction is these are not, we don't call these fibroblastic foci. We reserve that term for usual interstitial pneumonia. While these are focal areas of fibroblast proliferation, we instead refer to these as fibroblastic plugs. And they tend to have this polypoid look to them. So if I just move it like this, you can kind of see that it has this kind of almost dumbbell-shaped appearance. And then it kind of expands out here, expands out here. And so we often describe there's these polypoid areas of loose fibroblastic proliferation that have a mucopolysaccharide rich nature to them. And then in the interstitium, you do see some admixed inflammatory cell infiltrate as well. So this is a case of an organizing pneumonia. And this is one of the types of acute lung injury that you can get in the lung. And this can be response to many different causes, including infection, inflammatory conditions, radiation, connective tissue disease, and drug reaction. In cases where it's idiopathic, it's known as cryptogenic organizing pneumonia, or COP. An old term for this was bronchiolitis obliterans organizing pneumonia, or BOOP, but more recent literature just describes this as organizing pneumonia, or OP. In terms of pathology, we typically diagnose this as an organizing pneumonia pattern and then leave it to the clinicians to identify an underlying cause. And if no cause is identified, to characterize this as a cryptogenic organized pneumonia. There is a potential role for doing additional testing in some of these cases to look for a potential fungal or acid-fast organisms that could be causing this, particularly if you see associated areas of granulomatous inflammation. An important point is also this can also occur secondary to obstruction or secondary to an adjacent lesion. So if you see a small biopsy that only has a little bit of organizing pneumonia, but radiologically they're describing a solid mass, this could indicate perilesional sampling. So our next case here, we have a mediastinal mass, and you can see here there's a little bit of residual normal thymic tissue, where we see this nice lobulated architecture. And then we see a nice contrast between these darker staining areas and these lighter staining areas. So we have these dense areas of the cortex and medullary areas that are lighter staining that have these Hassel's corpuscles here with this keratinization. So this is our normal thymic parenchyma. And you notice there's not really any thick dissecting fibrous bands. However, when we go over here, we start to see these thick dissecting fibrous bands throughout the tissue. And so this is what you see in a thymoma. And this allows you to distinguish this nice normal architecture here without these thick fibrous bands. And then as we get over here, you start to see these thick intersecting fibrous bands going throughout the tissue. That is characteristic of a thymoma. And then in terms of thymomas, we subtype them in the WHO system into A and B thymomas. So this is a B thymoma as we have numerous of these lymphocytes and these interspersed epithelioid cells here. And this would be a B1 because we just see these single interspersed epithelioid cells, and we're not really seeing clusters or sheets of the epithelioid cells as we would see in a B2 or a B3 thymoma. And also there's some preserved areas of more medullary differentiation that is seen typically in B1 thymomas. A cytokeratin stain can be really helpful in these cases, as in thymomas, it'll show a dense meshwork of staining, which you would not see in a normal thymic tissue. You just see a patchy, wispy staining in the normal thymus. And then all these lymphocytes will be TDT positive as well, which can also help you. Our next case here is from the pleura. So if we look here, we can see an area of a pleural plaque. So we have this dense collagenous fibrous tissue that really has this nice layered appearance to it with these interspersed holes that are characteristic called a basket weave appearance that's consistent with a pleural plaque, which is typically seen in patients that are exposed to asbestos. If we move to the side here, we can see that there's this proliferation of these epithelioid cells. They do look fairly bland, and that is often what we see in mesothelioma, is that they look a little bit more on the monotonous bland side in comparison to carcinoma. And they're forming these tubular structures that are diffusely invading down and getting into the underlying fibroadipose tissue. So when these epithelioid cells invade into the underlying tissue, such as in this case, the fibroadipose tissue, or if it is using the visceral pleura into the lung parenchyma, this allows you to get the diagnosis of a malignant mesothelioma. We then subtype these into epithelioid or sarcomatoid. These are epithelioid mesothelioma. And it is important to exclude a carcinoma. And to do that, we typically rely on immunohistochemical stains. And there's no one stain that is perfectly sensitive or specific, so we usually use a battery or a panel of stains to differentiate that. In most cases, you should use at least two mesothelial and two carcinoma markers. Mesothelial markers include WT1, calretinin, cytokeratin 5/6, and carcinoma markers include BRCA4, MOC31, polyclonal CEA, TTF1 as well. And so using that panel, we would expect this case to be positive for calretinin and WT1, negative for polyclonal CEA and BRCA4. And so this would be an epithelioid, malignant epithelioid mesothelioma. Our last case here, we see a diffusely abnormal lung. And then as you get down to higher power, you see all of these multinucleated giant cells that appear to have this material associated with them. Unfortunately, on these slides, on these digital slides, we can't polarize. But if you do polarize this, you will see this to be polarized material all within these, associated with these multinucleated giant cells and granulomatous inflammation. And much of it is actually associated with vessels and involving the walls of vessels throughout that if you did a elastic stain would actually nicely highlight. And so this is all from talc or drug filler that you can see in patients who utilize intravenous drug use, where they'll take crushed oral pills and crush up the material and inject into their veins, then accumulates in their lungs. And you can see a mixture of things. In this case, it's mainly talc with this relatively colorless material that will be strongly polarizable under polarizable light. And so you can see that throughout the case. So this is a case of intravenous drug use.